During the first day, it was very exciting. We had many interesting research papers that were presented and lectures from our guests. Unfortunately, some of the guests had to go back home, and today we're going to have 4 presentations for you. Do enjoy the exhibits when you have time. Let's try to keep everything on time today, unlike yesterday, because we were very delayed yesterday. So during tea break, we beg you to come back within 10 minutes and nothing more, because we're gonna have a long lunch break, so you can mingle and mix at lunchtime. So keeping that in mind, and also we're gonna have a meeting at the end, so you cannot, please do not leave before that meeting. Certificates will be given out at the end of the day, so you will not be receiving your CU hours if you leave before the end of the program. Okay. So we're going to start with the pediatric session. This morning we had an amazing lineup from mostly the cure team and the pediatric side of the black line and the bar will be presenting. And to moderate this morning session, I would like to invite Dr. Brahano. Dr. Brahano to the stage, Dr. Messer and Dr. Nazanet.
SHAD at Gmail. አይቼው ነበር ትናንት ልጅ አይቼዋለሁ። ለምንድን ነው ዛሬ ደውልበት እኮ ነው አይመጣም ዛሬ ነው መልካም
እንደውለት ነው
አይቶ በቃ
እንዲገባ ማን ኦንላይን
አሁን ነው እንዴ?
ከ3 ሰዓት ላይ
ሚቲንጉን ቼክ ያድርገው። ስኬጁል አድርገናልኛ።
ስንት ሰዓት ላይ ስኬጁል ያድርገው? እንደውለት
ፉል ዴይ ስለሆነ ማስጀመር ብቻ ነው የሚጠበቀው።
ስንት ሰዓት ላይ ያድርገው?
መግባት ይችላል። ጆይን ይችላል መግባት ይችላል።
I don't know whether the book is ready. He's going to because actually certificates for upcoming questions.
Hello, my name is regarding a children's orthopedic surgeon, now hospital for sick children in Toronto. And I'm very delighted and honoured to be with you today. We spent 7 very happy years in Alexandria, and consider many of you my friends as well as colleagues. I wish I could you in person for the 17th ESOT AGM, but huge thanks to Dr. Ephraim and Dr. Garrett for this opportunity to talk about post-septic credit and management considerations. And also, thank you to the moderators, Dr. Nars, Dr. Bahuru, and Dr. Bahan. So this is a very challenging methodology. And of course, prevention is better than cure. Emergent hip arthrotomy is, of course, the mainstay of care in sepsis, but late presentation of the untreated child is actually still very common. I think the thing that we struggle with is there's a very wide variety of presentation regarding hip and fall morphology, and trying to decide which children we can treat that will improve upon the natural history is certainly a challenge. I'm trying to distill this into different groups, hopefully help us form some form of algorithm. We're trying to work through these cases. But overall, this discussion assumes that the underlying hip sepsis has been treated. And if there is any active infection, then of course, the vitamin and septicectomy would be needed before any thoughts of reconstruction. Hungary classified septic a long time ago. I don't think it's a complete classification. It doesn't talk about the septic hip dislocation, but it certainly does talk about many of the different presentations. It also doesn't mention about hip ampulosis, which is often something we see a great deal in the nuclear as well. And I think probably overall it's helpful to divide things into these groups just to help us work through what might be the right thing for the individual child in their own mind. But it is very possible to make children of us by making the wrong decision on this, and I'll talk more about that in a moment. But overall, to really work through is sophisticated. Is there established avascular necrosis? And often this is a very significant AGM, often with complete femoral collapse or absence of femoral entirely. What is the age of the patients? Is it painful? And is there simple bony ankylosis? And if so, is the leg in a very disadvantageous position? So the first scenario, the post-septic hip dislocation. Now, when can we improve on natural history? And we certainly can make these children worse. You can have a hip that is dislocated but pain-free, with a small leg length discrepancy, and you can put the hip back into socket. But it is very easy to make these hips stiff and painful as a result. And trying to pick a win is a challenge. And I learned a lot from an early case, what I thought was DVH. I've been a bit wise now, looking at the X-ray, but I did think that this was an idiopathic DVH case. And when I opened it up, I found very, very scar tissue layers. And the subtown capsule, the outer tuft obliterated by scar. And the femoral head was absent, so it was just a concave dish at the base of the femoral neck. And of course, this is the post-septic hip that you can probably see now as a very naturally descend to cyclic nucleus or naturally replace the cyclic nucleus. And no natural dislocation is sometimes suggested. And we really need to try to avoid operating on some of these hips where there is no femoral dependency for back in. Dr. Bacalli and I did a study with many of these post-septic hips, the ones we did decide to put back in. And I think one of the things that we found was that if the cyclic nucleus is growing, you've got a much better chance of having a good outcome. It's well worth when you see the child initially, they've got the cyclic, and you can bring them back up to 6 months and then you can hear and see if it's growing. This was the case in this child. We had a very early consultative sepsis, was then supposed to 3 years, and didn't operate until 4 years until we knew the cyclic nucleus was growing. It's a startup operation, but it's part of an usual case. But we put the hip back into joint with femoral osteotomies, and although there's certainly a short neck, the hip starting to develop quite satisfactorily and hopefully better than the natural history, and certainly minimize the leg length discrepancy in the child's been walking well. And I think they've been well served behind this. Another situation with a more beaten cyclic nucleus, seeing it grow over the course of a year, and then quickly get back in and actually reconstituting in a satisfactory way. So there are a small group of children who are growing cyclic nucleus. I think that we can potentially improve on the natural history by hip reduction. In the older child, often there is severe AGM or huge cartilage erosion. Sometimes it's less severe. Now on the right hip, there was clear established avascular necrosis. On the left, it dislocated, but actually looked very round. This child walking with a very severe limp, I think in part because the left hip is the left leg is very short, and she's using the hand to stabilize the lumbar right knee to help with the gaze. We did a local reduction and found actually the femoral head cartilage was really pretty good. And so the femoral head osteotomies reduced it, and you see much better for it. So there are still in some of the older children who might still benefit from local reduction if the femoral head looks round in a largely condition. But what if there was another system nucleus? I don't go ahead with the traumatology arthroplasty. I think the long-term results and what I knew was good for the natural history. And there are different ways of doing traumatology arthroplasty, but essentially you can stick the cancer and doctor implant it into the acetabulum, or you can put the whole traumatology into the acetabulum. But I think even in the hands of the advocates, the long-term results, even now beyond 5-6 years, these things become sick and start to become painful. And I just offer up what sometimes the natural history can be. Some of these children with severe AGM, a 16-year-old young lady who seemed to have the most likely history of neonatal sepsis, mobilized without any pain. You see, she hasn't developed any femoral head, most likely total head AGM, but she's got no pain. She's got a full range of flexion and extension, full sense of leg length discrepancy that can be managed with a shoelace, or maybe if she presents early in the pregnancy of thesis. But overall, traumatic arthroplasty would not produce such an outcome as this. And so I think in that, the child's pain free, and if there isn't a good femoral head to put back in, I would leave it be, and I think that is by far the best option in these situations. Second scenario is when the hip is reduced, but there may be proximal deformity. And I think the three questions here are, the one, is there reasonable joints? And we could potentially consider an osteotomy. If the joint is anchors, could you reposition it in a more functional position? If it is very painful and very degenerate, potentially public support osteotomy, possibly hip arthrodesis, and certainly a total arthroplasty would be the three options that we could face. But going to the first one, a child who's had hip sepsis in early childhood, who now presents with quite a significant limp due to leg length discrepancy and also condyloma gait. Can we make this better? Now, the head is certainly not it's certainly got some deformity. There seems to be an adequate joint space. Is it best off leaving it be? In this case, we did an arthrogram just to see what the hip would look like in a simulated balance position, like swimming fitness for reduction. Important balance, this might bring the counter around and help with the balancing hip osteotomy. She does seem to be walking better. I think it's safe to say this hip is, I don't know how long this hip will last, and I think in the medium term she'll be okay, but she certainly needs some further intervention in the future. But I think in some situation you could consider doing osteotomy. One thing I must say I learned is when there is significant cartilage damage and very short neck, brother, I have done femoral neck lengthening osteotomy, but by lengthening the neck, increased joint reaction forces and what was already clearly damaged joints actually accelerated the arthritis and the joint collapse quite quickly. So I've learned not to do femoral neck lengthening osteotomy with previous hip sepsis if there's particular cartilage damage. So I think I'll be cautious about osteotomy as large, but I think for the great areas it might be a reasonable option. Now, if the hip is anchored in a very unhappy position, reposition after these can be a real win. And we do see many of these children coming along in terrible positions, sometimes very severe flexion, abduction, and with a huge leg discrepancy, sometimes having this girl unable to be with that. This was a case, I think Dr. Tedros is in the and this is some of the cases we worked on together. You can see the hip is anchored pretty fused to the pelvis, and this is her knee. She's got such severe fixed inflection with all the other scarring, but this was all burnt out sepsis. And then to bring the hip back down into the functional position, use a lot of plate here, actually can make a very good difference to the patients. Sort of a leg length discrepancy, but at least they'll be able to walk on that affected side with a shoe raise or such like. What if the hip is degenerate and in a poor position with pain? And for these ones, another support osteotomy is, I think, a consideration alongside the physical arthroplasty. So this judge used 15, 16 clear signs of burnt out, probably very early hip sepsis with the femoral head organs left as if articulating behind and having a very severe painful anatomic case. A total hip replacement, I'm sure, would work very well in expert hands, and many of you are experts in total hip replacements, but this child was unable to consider that and report it. And I think the pelvic support osteotomy is a very effective treatment for children such as this. We tend to do a two-stage with an anterior approach to do the Gellerstein femoral head resection, and then keep it on traction for about 10 to 14 days on ibuprofen and methicillin to avoid topic ossification, and then coming back and doing the proximal femoral osteotomy, the so-called Shanson osteotomy. Actually, Dr. Timnum used to do these with a Russian arch and knee reconstruction and then developed this plating technique that I think works very, very well indeed. And it's just a simple 4.5 DC bent out to 55 degrees. And you swing the leg in, leading up the leg by that doing by 55 degrees. You make the femoral cut parallel to the lower border of the issue. You set a very small triangle of bone, and then you try to get the best you can of those bone cuts. Stabilize the proximal femur with the DC plate, which is helpful. You can pre-drill it to the proximal segment first, and then you bolt it to the lower segments. And that anterior 3.5mm reconstruction plate really does help with rotational stability and reliability. And it's the medialization of the shaft closer to the ground reaction forces of the body really helps with these children's gaze, as well as some people who potentially would be abducted as well. She's done very well with this. Often children can be free from sticks and crutches that they were using before, and sometimes they will still let out discrepancy that can be managed with an adhesis. But it can be a very effective operation to reduce the pain that these children have and to bring back walking pretty well again. But I would take it that the total replacement would certainly be a really very effective option in this case. And just to highlight the severity, of course, the condition, the pelvic obliquity we see. Some of these children, they come in with a severe leg discrepancy due to that very, very severe pelvic obliquity and often a fixed inflection. And the pelvic support osteotomy does do a pretty good job of leveling the pelvis, getting their leg lengths much better than they were before, as well as removing that stiff painful articulation that they have. So arthrodesis versus arthroplasty. In both of these cases, you can absolutely go forward and be a run-ball arthroplasty. But sometimes we do get concerned about previously infected joints. And in the case of tuberculosis, I think Dr. Jim Harrison showed the efficacy of management with TB medication. Of course, this is TB was burnt out, but going on to treatment before the arthroplasty and continuing for the month or so after. And that might be very helpful coverage in times of more of a staphylococcal infection, the like. Then we may want to also cover some perioperative coverage as well. In these two cases, I performed a hip arthrodesis. They were young labourers who I felt were good candidates for that. And it's a big old incision, which you have to dislocate the femoral into new bits and use coated blades involved in the cancer. Again, so that in the future there's potential conversion options for total hip replacements. But I think this is still an operation that could be considered in some if the total hip replacement is maybe less than ideal. So really in conclusion, it's a very challenging condition, and I think overall we just need to deal with the infection first. But we shouldn't rush in. If there's no clear win, many patients might well be best to deal with a leg discrepancy in the future. And certainly the dislocated cases, unless it's all come out, I would advise that just leave it out and deal with a leg discrepancy through diseases. The treatment options differ according to age, the symptoms, dislocation, again, ankylosing and malposition. But I'm really, thank you very much for this opportunity. I wish I was with you. Please email me if you have any questions, and I hope to see you all again before long. Thank you.
Thank you, Dr. This presentation will be by Dr. Is that presentation from Ethiopian? It's going to be the lecture on constitution. Yes,
So I always find it very difficult when people are so right after we pass with a good friend of mine, excellent surgeon and a good speaker. So speaking after him is going to be very challenging for me, but please bear with me. I'm going to be talking a little bit about post-infection deformity. I thank ESOT for giving me this opportunity to speak on this subject. I feel very happy. Whenever I think of a post-infection deformity, this is what comes to my mind. I feel like you have only one chance to identify. If this bone makes a small mistake, takes a wrong turn, if it's not enough to make the right decision at this moment, then the outcome is going to be disastrous. So I always feel like I'm being challenged by every case that I see such a deformity. And they come in different forms. They come with prostate injuries, they come with deformities, non-unions, small drugs, in all sorts of ordinary deformities. So they come in different forms, and they are challenging to deal with. Of course, we need to do our proper assessment. Do I always do, CT scan or MRI for all these patients? I don't always do it. We are very selective. What are some of the deformities very difficult to understand? Is just looking at the two-dimensional X-rays. In those cases, I may do a CT scan, and sometimes I may do an MRI scan if I'm considering there is a small involvement in growth rate, and I may possibly try to set up growth rate 5 cm. But I don't do this for this. CBC, CRP, ESR, I always do it because I want to make sure that the infection is controlled before I close. We need to consider the age of the patient. It's different with a child who's maybe 1 or 2, 3 years old, and the child who's 14, 15 years old. So age of the patient is very important. And we need to be considering that. And the type of work, they are multiple involvement. The extended involvement is also important to consider to make proper decisions. And one issue with the partial involvement will also be important. Whenever I approach these patients, I kind of list out the problem list. Problem list can be the patient list, or it can be a surgeon's. Okay, the patient list can be how bad are the symptoms. We were talking about pain. I always take that very seriously. If the child, especially around the hips, the child develops large pain, and if you can deal with it, just correct the discrepancy or something, it may not be a wise idea to try to operate, and because they may end up with a painful limb, and the outcome may not be as you expect. So you have to be very careful. Patient symptoms are very important. If the patient is not having significant symptoms, just don't look at the X-ray or recommendations. I also look at the function of the patient. I also look at the nutritional status of the patient. A lot of the only come, especially those that are uncontrolled infections, become significant about malnutrition, especially in such a chronic part. And I also want to know the goal of the patient. Do they have an achievable goal when they come to see? They always want to be working nicely, working normally, or functioning well, but it's not an achievable goal. So we have to discuss with the patient what we can possibly do and what the final outcome will probably look like. The other is the surgeon's list. Can I get it to him? If it's an anemia or a program, can I get this into him? Can I manage this before me and get the patient to be functioning better? Okay? Can I restore the mechanical access? Can I get a normal orientation? So this can be the problem is for the surgeon. So I need to answer this before I close. Treatment strategy, you can be some of them is just growth combination only. Sometimes you may have to do ablation growth, maybe on the outside, or sometimes the deformity, if there is significant involvement of the growth rate on the affected side, it might be better to just ablate the rest of the growth because it will continue before me, and then you can give the deformity later. You may also have to see if you want to do an acute correction, it's possible, or you have to do a gradual correction. How is the soft tissue covered? Can I get a good soft tissue covered? Or a lot of times you have to do a combination of all this. Is salvage a possibility? Can I salvage this? Or do I have to do an operation? That's also one thing you have to consider when dealing with these children. Sometimes, if you have a bone gap, it may be what it is, maybe the biology, maybe it's slightly different, it's not properly mobilized, maybe especially the very young ones. Maybe you apply, for example, a finger, then you just apply each spike cast and it may be in the infants, maybe 1 to 2 years old. Sometimes we have to immobilize with analysis, and it may be. But a lot of times you have to do a debridement and compression or injury. Or sometimes that may not be enough. Bone may be, the gap may be too big. You have to do a bone transfer or a leg Z. There is this technique called the orthopedic first technique, developed and introduced by Professor Osli Gamal, maybe he's a teacher, maybe a friend of mom way of some people who did the training in It's important about the patients that he does before even degrading. He does apply suffering, he does orthopedic, and it's the same thing. He extends suffering, degrades it, and then he says he gets better outcome by doing the orthopedic, by using the orthopedic. I'm always saying about it. Anyways, we have a female friend. We use that under vascularized fibula, sometimes vascularized fibula, or sometimes we do a stage transfer of ipsilateral fibula, if it is it's good. Or we also have a bone graft, we can do bone grafting for the non-union, make the non-union to be, and then you can do the deformity correction later on. Or sometimes you do the muscle induced membrane technique. So let me just show you a few cases. As this was a 60-year-old girl presented with schizophrenia, pain discharge of the right tibia about 3 years earlier. She didn't have any current discharge. This is how she presented. I don't know how much you can see. But it looks like she had gross injury. She has multi-apical deformities. In the tibia, you can see also the lateral rib. She has anterior angulation. So, how bad is the deformity? So, this is the medial distal angle, distal tibial angle, which is 67 with the lateral, about maybe 25 degrees deformed. On the lateral rib, you can also see she has 26 degrees of angulation. I don't think that's definitely I think she has these deformities. So I go to my problem list. So she has prosthetic injury, she has antivirus deformity, multi-apical tibial shaft deformity, she has leg discrepancy, possible leg discrepancy. So what are the options of treatment? So this would be the options. And I do physiolisis. I will have to do an MRI and see how much percent of the physis is involved. But in post-infection physiomyelitis, the usual finding is usually extensive involvement, and the physial bar sections usually not very sensitive. And in her case, they are more with significant identity MRIs. Gross modulation or completion of the gross osteotomy frame, gradual destruction, correction of the deformity, and also the leg discrepancy. Or you can also apply So these are the options. I decided to do with gross modulation. So this was the angulation. So I applied screws to arrest the growth on the left side of the distal tibial physis, and also applied, I don't want the fibula to overlay this, so I applied screws to hold the growth of the distal fibula. So that's gradually improving from. So this is not a good measure, but 89 degrees same. This one is 89 degrees. So that's when this is where I want to stop. So now the screws are involved. This is how she is, and these are the measurements. You look at the first one, this was 67 degrees, meaning the acute side of 67, meaning this is 150 degrees, and you can see this is restored to 86 degrees, 87 degrees on the lateral side, which is the normal and acceptable range. Even the mid shaft and deformity has improved also. So the gross plate was injured, but was like a complete injury, and it kind of broke the injury and started growing even on the digits. So now the 7-year-old presented a complaint of short of the left morning, with history of swelling and surgery, and past discharge in the neonatal period. And she had significant with discrepancy she walks with the shoelace. And she absolutely hates the shoelace. And she had a complete gross arrest of the discharge fever. You can see this view, the non-linear view, and you can see she has a raise of 7.5 centimeters, a lot of 7.5 centimeters, showing the amount of prevalence discrepancy. This one didn't have any deformity. The main problem was only prevalence discrepancy. So my problem is discrepancy because very easily the discrepancy, predicted the discrepancy is about 10.4 centimeters actually. So the options of treatment, she can use an extension prosthesis if it's possible. I can do the lensing and time physiology on the collateral side, or I can just do a side translation in a prosthesis. Those are my options. I decided to go with the lensing. So I just use a simple frame. This is orthopedics frame, orthotomy, and relate the gun, and remove the space and put in the rasher. I know the rasher looks a bit short, but we put in the rasher just to protect the fracture. So the length is that one, and you can see the length is just almost restored. She have only remaining centimeters of discrepancy, which we are managing with shoes and program. My plan is to do a time physiologist on the collateral side. She is kind of short, and her mom is also short. And when I explained the procedure, the next procedure, she does not want to be shorter than that one, and she said she would rather have another lensing. So maybe we're going to have to do another lensing once she completes her course. Another one for Iran, he had a post-cut injury as a child, very young child, followed by swimming in this child was operated similar to and developed progresses. Before we did it start, when she came to us, she had a significant deformity, as you can see. The lateral distal here was 33 degrees, so about 60 degrees or 57 degrees of deformity. So my problem is starting because the injuries in the valgus deformity, 5 6 close, she's already 14, and she has many of the fibula. The options of treatment is active correction and or decrease the discrepancy, or do a osteotomy and gradual correction without having to lose any length. So I decided to use a frame and do a gradual correction, and we did an osteotomy with the distal tibia, and you can see these two wires. They are falling onto the distal fragment. So they're falling onto the distal fragment. You can see the amount of angulation by post on the lateral side is a huge post compared with the very tiny post on the median side, because it has no significant, as I say, she has about 60 degrees of deformity. I'm trying to make it parallel with the joint line. And this frame is falling onto the foot. And so we did a gradual correction, and she corrected. It wasn't a complete correction, but you can see the amount of ambulation that would be having now. So I was scared. If I continue, correcting this deformity, she may end up with significant supination and also operation. So this was when I decided she may have some flexibility in the foot, so maybe she should be okay with this. I stopped it here. And it all hit up. Final outcome, she was final follow-up, she was about 81 degrees, lateral distal tibia. Similar story, 14-year-old right tibia injury, about this was the low suspicion. He came with a huge sequester, as you can see here, and one was sticking out through the skin. So, and he had infection was not controlled. So, first thing we do to control the infection, so we have to take out the sequester. He had a clean infection, he had a necrotic segment, he didn't have a significant bone gap without that segment. Skin closure was a problem, nutrition, legs is visceral, the problem is that we have. So the options of treatment were debridement, framework from postment, bone grafting, this is one option. The other option would be debridement, frame, close the bone gap, acute treatment, later. But he had a significant bone gap, and it would be very difficult to close it acutely because there will be a lot of munching on the soft tissue. But that was also a possibility. Another possibility was debridement, bone gap, frame, bone transport, and grafting, or option of amputation was there. We have to discuss even the option of amputation with the specialists who significant bone gap. So we decided to take out the sequester here and the bone gap. As you can see there, you can see the middle ring here. The distal ring is fixed to the bone, proximal ring is fixed to the bone, middle ring is not, it's just waiting for infection to heal, infection to get under control. So the infection is controlled. Once the infection is controlled, we apply some wires to the distal ring, do the prostotomy here, and this is regenerate, you regenerate. So we keep bone transport now. So we transported about 10 centimeters, we closed the gap, and once this regenerate has formed very well and strong enough, then we took it out. This thing looks like it has a little bit of an ingredient there, but we definitely need a bone grafting. The peritoneal, once the infection is consumed in the fire of the regenerate, this is free. And maybe I have to be honest, I was very skeptical about this. This is, as I said, your suspicion. I was thinking it would be trying to fill out this much gap with just a bone transport on a bone that does look like it's very healthy. I was very skeptical about it, but as proving this thing that these are upside, infection is consumed with the fire of the regenerate. Actually, the infection is controlled probably because of the regenerate. The tibia down looks even better. We have a nice regenerate, bone gap is filled, so it's only related. Just taking out that debridement, taking a step with the fibula, and bone graft. Similar story, 2 years, 8 months old girl. This was my forearm infection, debridement was done somewhere else. She had a significant bone gap when she came, and she's very young, close to an injury, significant loss of the radius. We decided to go with the easy way, which was make sure that we control the infection first, and then try to create a single bone forearm. So we took the distal hand down into the distal end of the radius and try to get it to the right. And divide nicely, as you can see. Another 1-year-old girl swinging with the right thigh, and it was tossed to the hospital with support treatment, but it was not operated. He sustained a forehead and pathology fracture, which was treated with a reduction and fixation, but it failed. And we have and he was saying to us, this is what he had. He had significant sequester there with a big bone gap. The baby had a little bit of regenerated, but not much for me. So we took that out, put that antibiotic bone season frame, fibula graft, which is held with these skin wires. We have 2 strands of fibula here. Then you can see on this side there. And then bone graft it was added, and he healed that. This is a 13-year-old girl. This is the one that Rick was talking about. This was X-rays. This is how she was walking. when she came to us. This is how she was walking when she came to us. So you can see the level of the bulbs are higher than the level of the head. We took her to the wall. This is very challenging. If you have this, as if this is the fever, and it's confused to the hip. So if you want to paroxysmally and correct this deformity, she has the 110 degrees of this flexion deformity, and this ankylosity. The only angle that I can correct it will be, two ankylosity here and attach it to the, as this is the proximal distal, anterior posterior. So attach to this posterior end that will give 90 degrees of correction only. I cannot correct the whole 110 or 120 degrees of the deformity. Because if I do it more than 90, then I will have minimal contact between the two fragments. It will be another challenge to get into here. So we corrected only 90 degrees. This is what she finally had, and this is how she was walking. So even just simple repositioning osteotomy is what we did. So just simple repositioning osteotomy can also give you a good outcome. Sorry about this. It looks like I have lost my final slide. So most important thing is follow the principles. Make sure that you follow the principles and study the expert, study the patient, and make sure the first thing is control the infection. Okay. So the first thing is control the infection. Then you align it, and stabilize it. Once you align and stabilize, then what you need is for to stimulate it to it. So those are the three important. So stabilize, stabilize, and align it, and stimulate it to it. Those are the things you need to do in most cases. Thank you very much.
Thank you very much for this interesting talk. The next will be
Good morning again. Welcome for second day again of our 17th ESOT meeting. Thank you for your attendance. This is, I think, we are making the setting the morning already. So we will proceed with the setting and the display of which is theory privilege hospital work while I was looking at my intervention. It was meant to present the 16th AGM actually for a technical issue. It was set for the 17th. So the caregivers and all the crew team, with the machinery team and the rig are all parts of this activity. And so this is my outline. And it's a positive meaning. Literally, we're doing obstetric sequelae is very much common in our country, in order for practicing hospitals. and generally present led with lots of complications before the positions and the So, I'll say by the verdict, it's not, good to be in the face of such a challenging case, but we have to be on the way. So generally speaking, pediatric knee fusion, especially from a patient report outcome point of view, it's not very investigated, so we try to come up with a patient reported outcome from pre and post op of pediatric patients with septic CPA after undergoing infusion. In another group of patients, generally, as you all know, this infusion is actually kind of common post neoplastic and infection, and from some other different conditions in adult patients. But it's also created with expecting reasonable outcome post-surgery outcome for non-positions and before knee. In our interest, we see from post-sepsis point of view, but from post-trauma and other pathogens point of view, it can be considered also. So, I think it was just 5 years data, 2018, and we examined that in 2021. And we had this low extremity functional state both pre-operatively and post-operatively to know how are the functional level of this group of patients pre-operatively, and we were interested also on the improvement post-operatively, as I said, as a low extremity functional scale. So generally from this scale, if there is a 9 points improvement, it's said to be that's the minimum clinical significant improvement. If there is between pre-op and post-op, if there is 9 score improvement, that's the minimum clinical significant improvement. So anything about that is said to be good to examine. So very difficult to think, but this is a lower extremity functional score. From unable to perform significant difficulty to no difficulty to perform day-to-day, which is sport activities, schooling, running, jumping over weights or stairs, and the next. So almost assessing the functionality daily, and it's also score that we used, and nurse assistant working with you was mandated to do a pre and post of score of these patients together with certain operated in the follow-up. So we have this operating technique. During after the decision for surgery was made, and distal lateral time causing the joints, some 2 centimeters. These are the human head, and the main purpose of this decision is actually for common problem and exploration, because some of the deformities are severe enough to bring peripheral attention in neuropraxia, with suspect low benefit deformities. So this is a clinical picture after identification of the common programmer, and generally it is otherwise we were really the problems like longest origin, and we somehow dissect also the problems that was to prevent significant action from the origin that so and we will keep this incision the amount of tension that will cause when you correct mostly the fixed problem. So the second incision was longitudinal anterior incision with the median approach, which the workhorse of majority of the pathological conditions. So with this approach and the distal and proximal excision was performed with orthotics or the tailor spatial frame testing, and the level of excision of the distal femur and the proximal tibia was a little bit different between the two fixations. A little bit minimal with TSF because we took a gradual correction for purposes to just show the actual activity use. And the temporal prioritization was used before application of the frame. The second picture with excited distal femur and proximal tibia, As it is to be active correction in orthopedics, the excision will be a little bit higher, and at times in order to we go the shortening in order to increase the tension of the neurovascular structure, especially of the posterior knee neurovascular structure. And in this application, there are some modification of the routine telesocial application. In orthopedics, we use, whenever we are using orthopedics for the same technique, but in cases, we use a kind of inverted frame application, making the master part more on the tibial side than the femur side. And the main reason for that was because of the swing after first, second day of surgery, and kick from the patella, it was not smooth and it was not comfortable with a classic position of the case. So we used inverted frame application, making the master part was tibial side, and the correction will be gradual one, especially this was used for severe deformities, which we end up, if we do it actively, we could end up with complications, neurovascular inside suspending. So some of the cases, as you can see, fixed severe flexion deformity of the knee, posterior one, and this was corrected with orthotics, and after distal proximal, distal femur and proximal tibial excision. It was really straight. Maybe some degree of flexion can be accepted with some degree of also some centimeter of gradient discrepancy, especially for ground clearance, might be accepted. But at times we might end up with an NLP. I'll show you the training. Some of the complications can be low gradient discrepancy. So maybe a centimeter or two of gradient discrepancy post infusion might be really functional for ground clearance, but anything more than that might be symptomatic. So you can see the fusion in the last X-ray, the fused completely infusion from severe fixed flexion deformity of the knee. So another one, which is also there with frame, that's it. And as you can see, actually this patient was having also a kind of significant requirements as a compensatory issue, and with this record was done, and you can see the children like this in children, if generally you take about 6 months earlier than adults with really unite. So this is a kind of demographic data to focus on the outcome, and generally we have got 2 to 6 times the minimum clinical significance, which is 9.64. So the maximum was 6 times the minimum score, that's 9. The minimum was 2 times, that is about 80. But generally there was a minimum increase of 36, a minimum score, which is about 4 times. So this was the patient data. Because we have some complications, patient infection, infection, there is discrepancy. One of the cases was having component neuroproxial, which is spontaneously, and the AGM was reported in one of the cases. So this is the score improvement from about 30 plus infusion. There is an improvement of nearly 60, this is plus. So significant functional improvement based on this reviews. So as I have said, we seek to come across with lots of data post the patient report outcome and post infusion especially, but from our case, we can anticipate and expect a reasonable functional outcome from a deformity post-septic functional or low functional level to functional ability. Knee joint can be given via infusion using orthotics and special care. But in terms of complications, due to these complications, including infection, delayed discrepancy, urinary issue, and deformity recurrence. These are my references. Thank you very much.
Thank you, Kanu. So coming to continue the next presenter, and I think Dr. Bishop, but I think Dr. Bishop has issues so can't unfortunately. So we're going to continue to Dr. Kanu to present us the next presentation.
Sorry, Dr. Bishop tidak available online.
It is a priority. We continue on Zoom. We're supposed to be in us today, but personally, people make it. So, welcome, check this mic on Zoom chat. Thank you. Thank you for the presentation. Those inputs are very important in calculating attitudes and making peak correction between this. If you use eight plates, it's simple, but sometimes it may challenge, especially if the patients are not coming to follow. That would be disaster because we are going to correct one gas and again in virus. So always need to have the patients who will be committed to come to the clinic and you are supposed to use eight plates in vacuum. So we go to the next presenter.
The student administrator of Telegram for his second presentation on base 17th AGM result reached this time.
Okay, thank you again. It's me. So this is a kind of to give a highlight on our local experience in Uganda for registration hospital for President Technique without CR. So I will provide this. So as you know, generally pediatric lower bone fractures are common pediatric trauma scenarios, and female taking less than 2% generally, especially female. It may happen at different age in the management. The orthopedic management depends on the age, fracture personality, the growth position, growth rate status, and availability of implants and personnel from technical point of view. So generally, from age 5 to 11, 12, this flexibility will last particular names. Especially for legs and fractures with weight of less than 15 kg, the active modality of management. But as you know, in resource-limited areas, these are limited by posters, so both young and flexibility and safe management will available. Generally speaking, there are different levels of evidence for obesity management, be it non-operative, spinal RE, illegal subtraction, or flexibility, locking, rigid, triangular milling, extensive plating. So all are the options depending on the situation, but the level of agreement and the level of evidence is variable for every option. So, for example, for flexibility from age 5 to 11, we do have a level of evidence of 3 that this population should undergo, especially legacy fractures, should undergo flexibility options. So, actually, we use for other global fractures cyanotic, and we try to customize some of the techniques we get from cyanotic into flexible nailing. And actually, we hypothesize that if we do this, landmarking and period planning and intra-tip strips, we make it an outcome comparable with image design or with availability. So it was actually starting from 2022, we had a chance to get the CR, so we converted accordingly this project to CR, that the data was from 2021 and 2022. So this is our flexible nail set with inserters, extractors, and different sizes of flexible nail available in our lab. So surgical technique, one of the surgical technique we used was the landmarking technique. So one of the landmark was the superior patellar bone. We planted externally and locate where the superior patellar bone is, and fracture site as we make our incision, because this is a mini incision technique for fracture reduction. So the fracture site should be palpated in the market. And the trochanteric area, including the greater trochanter, should be palpated in the market for measurement both intraopen and post-op. So the pure X-ray is very important because generally speaking, the superior patellar is here, and the growth rate is usually between the upper one side and the lower two sides. So having this landmark on X-ray is very important because the patella has a different position on the background of femur fracture, or they may have some patella position issue. So without X-ray, we may not take it as a guaranteed one, but with X-ray, somehow to dictate our position of the growth rate. So the pure X-ray is important to know this growth rate correlation with the superior patella bone. And then intraop, we made this is actually POI. This is the area where the superior patellar bone is palpated in the market. We make sure the location also is the right place. And this is the center of incision for our lateral and medial insertion site incision. We can be sure from the X-ray and from this marking, landmarking, we can be sure that we are away proximal to the growth rate of the distal femur. And this is 3% incision over the fracture site, another landmark, which is important. And we usually do not deliver out. We usually use the finger technique reduction with gentle traction. So the principle of the nail size and nail diameter measurement is we keep the same standard of the nail diameter and the nail length measurement. So after that, we make an incision for entry. After provisionally reducing the fracture, we may control it with our finger while advancing the nails. Or if we have any difficulty, we may use forceps, a component forceps towards that of mostly one because of the incision size. So we made an incision for lateral incision for entry, and this one is the lateral incision, and this one is the medial incision of 3-4 centimeter using our landmark reference. So generally, you have done about 8 femur fracture patients, all closed. With different mechanisms of injury, legs stable fractures, and we follow them for about 3 months, especially checking their knee flexion extension status, weight period, and the squatting status. Actually, this patient were followed for about 150 removal, but for this relevant condition, we incorporate up to 12 weeks follow-up, and mainly we take also the silent follow-up protocol. Okay, we flex over 90 degrees, taking 3-4 degrees, and able to squat and spine for pediatric commercial fractures. So to see some of the cases, generally these are small number of patients, but from all the criteria, they all did fine. To see some of the cases, this is the 10 years old male for long history, and he was having medial cell femur fracture and fixed in the primary flexor primary region of previous image 1 without image identified. And this is after 3 months of follow-up, already calluses under formation, and there is significant malalignment or deviation. After 3 months, and patient was able to wait their NSC and was able to start his mind. Another one is for 9 years old male, road traffic accident, leg is stable, significant overlap. So for this also the same technique, like 7 days with mini incision fracture site and landmark incision for entry to avoid cross plate, and majority of almost all incisions that didn't compromise the cross plate from a landmark point of view. 7 years old female, this was actually the one which was having some complication. We penetrate the proximal cortex. This was, I think, the first or the second of my case, and it shows having a proximal cortical penetration. We have witnessed that. So what I do is I use a tactile sensation of the presence of that nail intramedullary and how it's when it's having a contact, how easy it is, and I use also from external, the same size of nail, and measure from external and rotate with the gross distance where it is, because we can't check this with it was not prominent and didn't compromise sitting and intellect, so we didn't commit for removal this patient, so we followed as it stands, and 8 weeks follow-up, there was a bilateral transformation, and on the other controls. After patients after healing, between 6 to 9 months, they were complete healing and the nail in situ, and removal was decided, and I don't usually X-ray them after removal. So this is a patient with cortical penetration, and removal was done after 1 year. after healing was declared and all parameters were complete for that. So generally, in low resource settings, options are many, but if we have a chance to get the flexibility and the same with science experience, the landmarking, taking the tactile sensation, the feeling of intramedullary access of tissue, and making an opening over the fracture site will give you an extra advantage to make sure whether your nails are intramedullary or not, and giving the same size flexibility outside will help also to know where you are exactly from this point of view. So, yeah, from this little experience, we can say we setting practice because AGM, we can do it with image intensification. Now, somehow we have been using image intensification here that because of the CR occupied or the time aesthetics are not ready. So if I'm not able to do the CR we practice to do this without CR in the current practice. And we are planning to check comparative study between the image assisted and without CR studies because we did that before the CR availability. Now we are doing also with the CR, so we make a kind of comparative study with that step. These are my systems.
Thank you very much. It is an interesting talk. So the next presenter will be Dr. Varano. The senior consultant, one of the pioneers who has contributed to the development of orthopedics in Ethiopia. So he will give us his design in treating cardiac new implant design.
Thank you very much. I think this innovation. This innovation is not for pediatrics, it's for every bone fracture. For that, I designed this with my dream for the last almost 30 years. Now it becomes real, and I got the temporary patent for this. I will explain this design. As you see my name, I'm a retired orthopedic surgeon. I've been working for the last 34 years, and now still I'm strong. My objective is I have to use the field of innovation, and then what's going to build to this art. And then I'm going to show you a big summary of this device. Specifically, the device compressed, which is different from the previous one, and then how it works, and I will show illustrations. The field of the innovation, the current application relates to three small size, long bones, femoral neck, with a simple way, without using many sophisticated devices. It decreases the operation time in order to improve the surgical fracture fixation to facilitate fracture healing and the prevention of new fracture. Previously, what was the area which scientists they designed? This pure art, it is difficult to fix to them a brittle bone, self-relocking, expanding is from inside medullary canal, induce a fracture in some condition on the process, even on the fresh fracture. No destruction of the fracture as needed, avoiding shortening of the limb. No compression of the fracture as needed. It's difficult to remove the implant. And then it is only limited to treat only long bones. These are some of expandable nails that was designed in 2019 by a Chinese guy. And then this is the first expandable nail was introduced. The second one is designed by USA from 1991. And then this they push the fluid. This is in a reduced way, and then they injected the fluid, and then that implant can expand the pressure to hold the long bones. The other one is, this is another USA patent expanded orthopedics device, and then I think we use sometimes, for humerus fracture, but it's still difficult to hold the affected bone. This is another in 2020 in Germany. They designed, but it is not tested in human beings. My objective and summary of this invention is a type of expandable implant used to fix small size bone, long bone, femoral neck, fix as a prophylaxis of brittle bones, such as osteogenesis imperfecta, osteoporotic bones. This is a self-locking inside canal out, disrupt the fracture as needed, avoiding shortening of the limb, non-induced fracture, compress the fracture as needed, and easy to remove. We can use almost to all bone fractures, from the small, which is scaffold bone. Additionally, it avoids really reduce radiation exposure to the both patient and the surgeon. Avoidance of the interlocking screw is minimally invasive and shorter procedure time. Our expandable nail, it comprises three components. The first one is the pulling and pushing device. The second one is expandable device. And the other one is the outer case with three purposes. These are the illustration of our nail. This is a cover of the screw ends. This is a pushing and pulling device. This one is expandable device, and this is the outer case. In this case, we are using our anatomical nature of this look like a bone and socket joint, such as the femur, and then we design on that base. Here, if we see expandable fixation device in function. Already, we screw on the top of the pulling and pushing, and then these pins are come out from the outer case, and then from the inside canal of the bone until they reach to the cortex. And then this expandable nail goes down and then touches to the bottom of the outer case. And then it changes the nail is very solid type of nail. That is what it shows by screwing the pushing and pulling device downward, expandable pins slide each on their groove on outer case until they reach holes made for externalization. From outer case to penetrate the inner part of the bone until they cross cortex of the bone. This is especially in a long bones. And ribs to bottom space made for expandable device, contact with the outer case in the device become solid nail. That's what we were telling you. This is the nail ready for use. It is how it has to be in the long run. This is the outer case which helps us. It is this is in situ fixation, outer case. More our function is doing on the outer case. We see this hole where these pins are externalizing. If you see the whole holes are the same size. And then when we screw, the piece come out, there is no movement on the bone, but the expandable nail goes until it achieves with the fixation to the bone. This is how it works. This is the first function of the outer case. The second function is compression of the fracture. In this case, the proximal part, the diameter of the hole is the same as the diameter of the pin, but it is longitudinally, and then the pins, when we compress, they bring the proximal fragment down to compress with the distal one. As you see, the distal walls are fixed. In this case, the distal bone is in the fixed place, but we move the proximal bone to bring compression to the distal ones. The other is the distraction. When we have a shortening of the bone, in this case we use this modality. The distal walls are bigger and then its diameter is longitudinally. According to the shortening, we can, when we screw, the proximal bone is fixed to the bone, but the expandable nail goes down, and then the distal bone is, when we screw, it goes down to bring together. That is how this external device is used as a distractor. The last device that we have is an extracting and introducing device. This has about 5 millimeter threaded screw, and then we screw the whole system, and then you can tap it to go down. Previously making a hole. For that, I think this device is already patented, and then we are looking for people to work with us industrially. This is what this implant look like. Thank you very much. I think we have all our presenters are presented, so now we have time for questioning, and if you have any questions from the audience, I call up the speakers to come to the podium and then ask some questions. It's also very interesting, so I think we are going to have so many questions and we not have more
Sure.
upcoming, so I encourage you to ask questions, because it's a very important task and security country have process studies here.
If infection develop, let's remember how much we this make this clear, okay? Is it clear? Not clear. Not clear, okay. What is the purpose of the bone at once? Okay, very clear this question. And if that is what I came across is that the bone graft and the cement, for how it should be kept there. And if in between, if infection develops, that should be removed, what should be, okay? Is this clear now? The second question, it's wonderful that you use flexible labor in children. I've seen that you increase the mother and media. Until in Europe, they were so-called intermediate sections, the same as flexibility, which is used for either people fractured in several country region. So you remember what I used there, only a media put aside the entry, okay? The 1 year after it is inserted, it is rotated, just like that used, so it's stabilized. Here, the main difference what I see, it doesn't have any body or gravity. It's not migration apart. Running migration doesn't occur because I didn't see. As only all this like a rush beam, I couldn't see on the picture, which is correct, okay? So the question, of course, the migration field. One, the other is why it's necessary to enter both lateral and medial. Because it was not possible to notice by entering this on the same side or on one side. Okay. The third question to Dr. Baru. Thank you, Dr. Baru, for introducing such a new innovation. My question to you is that this expansion made it is not so to the bone or just local area that we like expanded, just to as if it is to replace the interlocking school or purpose that should be okay. If it is expanded zona to total or so of the rest of the bone, doesn't compromise nutrition between arteries. Because one of the main problems is that the feed is always the best always nutrient artery is part of this bone obstruction. Thank you very much.
Thank you. Thanks for the informative questions. So that gives a chance to the speakers to answer them before taking more questions.
Thank you very much for your question.
That is why we designed this type of name. This name is selected. Only very few areas are contacted. Not the same as the previous one, where the whole, especially in medullary long bones, it will not compress. It's simply, I think, according to the length of the bone, maybe in 3, 4 areas where there is no compression in the endoscene of that bone. For that, I think from our design, that's one of the reasons why we selected this volume. I think I answered the question.
Okay, thank you, Dr. Awal, for the question. The bones events are usually temporary, but the ones that we put in for resource, they're usually temporary, and we use them just for antibiotic delivery, gradual antibiotic delivery, control the local infection around them. So they are temporary, and they are going to be removed in 6 weeks, and it's also believed that they induce membrane, when they use it as a synthetic. There is an induced membrane that forms around the bone cell. When you incise that membrane, just think of it as a periostate. So you incise it, you make sure you keep it intact, and take out the bone cell carefully, and if you that gap is a bone graft, then you have a better union. That's a synthetic. So it's a temporary one, and we remove it at 6 weeks.
Thank you very much. I think important questions. I think the migration risk is the first one. From our small kids series, we had so far, except the one we had cortical penetration without that we found that we did post-op for no research. So the size of the flexed knee, the proper measurement of the canal diameter, so about 80% of that canal should be hit by the two flexed knees. Half, for example, if we measure about 9 or 10 millimeter, that is about 80 millimeter size, 4 millimeter each flexed knee will be used. So the larger the size we use, the less likely of migration to be there because of the crowd and the slippery fixation is another important concept. So this slippery fixation will be at the entry site, over the fracture site, and over the intertrochanteric area where we will happen. We can be sure over the entry site and fracture site that without CR, it's very difficult to be sure we do have good fractures over the intertrochanteric area. So let's prevent that with the size of granular and slippery fixation appropriate application. Otherwise, I actually start weight bearing as a tolerated. I don't usually delay weight bearing, making sure that this is the same fixation. So from weight bearing, from suspecting if it's a smaller size and technically we are not able to weight, definitely risk of migration is a good concept. So we have one so far. Why lateral and medial? I think for retrograde fashion, the advisable method is to use medial and lateral entry. But if we are going from proximal femur anteriorly, then the entry will be from lateral side mostly. And radial fractures will be one nail only, so for one for radius. But for retrograde from distal femur to the proximal one, the advisable technique is to go from both medial and lateral. That gives the 3-point fixation very good fractures, and support both the knee and the lateral column fracture very well. And there are no such fracture surface from the point of view. That's the advisable technique for this lateral fractures. Thank you.
Yeah. So I think for the sake of time concern, we are going to stop here. Round of applause for our presenter stage.
so much our presenters and moderators. Very interesting topics. So we're gonna go out for a quick tea break. Don't forget, we're already running 25 minutes late from our program. So 10 to 15 minutes, that's what you have. So grab coffee and run back inside. We're gonna have so many more interesting discussions afterwards. Thank you.
Kalau apa yang berkaya kedua soal Signor, ci vanno giocare a combine yeah.
Works right?
You can just bring the laptop.
Give me the laptop, the laptop. Okay, 50 minutes. Yeah. You have the mail? Find the mail and call everybody.
Yes.
Like if you have the
Yeah, just bring it.
When choose this?
yeah, sure. Yeah.
ከዛ ደስ ይለዋል። ማለት ይቆራል ይገባቸውናል።
እና ሰው ይግባ።
Can we please proceed to the conference hall and continue the sessions? You get your friends from outside to come in. Thank you.
ለኔው
So, Dr. Nadim Rastov is ready to proceed with presentation from Hawassa. Mr. Kaido is our colleague and friend. He is a well-educated subspecialist in charge of the referral hospital and traveled all the way to this audience from 1% country. Then you are talking about risk factors for delayed presentation among acute trauma patients in the southern part of Ethiopia. So maybe you can start. Proceed. Okay.
Thank you, Professor, for your introduction.
our present risk factors for the presentation. Among acute trauma patients in southern Ethiopia, it's a left center general laboratory study. It's part of our thematic study. So we are getting support from Hausa University, technical and financial support. This will be the outline of my presentation. That's an introduction of the team, methods and material, result discussion. Conclusions. So as you all know, trauma is only because of morbidity and mortality. And in 2010 report, the WHO accounts for 8% of deaths, and it is 30% more than the total deaths occurred by malaria, TB, and HIV. 90% of this mortality occurs in low and middle-income countries, and most of the patients present debate. This is a definition by Lancet Commission. Patients with open injuries who come more than 2 hours are considered as delayed, and patients who come after 24 hours are considered delayed for closed injuries. And as patients present delayed in low and middle-income countries, the treatment outcome is also poor because of the evidence, and this significantly causes the morbidity, increases the morbidity and mortality as well as economic burden. 60% of the trauma is completed by musculoskeletal trauma, and traumatic brain accounts for 75%. So together, head injury and musculoskeletal trauma accounts for 95% of the trauma cases. So in Ethiopian context, we all know that there is high prevalence of road traffic accidents. Mostly this is associated with most of our risky behaviors, like most of the patients in our region, they don't use helmets, especially motorbike riding is common in southern region, and most of them don't use helmet. Most people do not like to use seatbelts, and in motorbikes, you can see a lot of individuals in one motorbike. There is no control in the number of individuals in the motorbike as well as in a car. And there are also conflicts here. So these are some of the pictures that you can see, like in one motorbike, you can see 5 or 6 individuals. These people come outside of our side, so that's in our side. You can see people like this. And this will simply happen in trauma in our areas. So this is actually whatever that the video that we get from this is still happening in our country. So people are very adventurous, and we will see the complications. So significant number, there is no actually study subject that from our limited resources or limited studies, we see that patients usually present delay than what we had expected. And there are 2 studies which use as reference. One is an enormous study, and the other is a study in Malawi. In the enormous study, they use the Lancet Commission for Global Orthopedic Classification, and they say that 71.9% of ortho fracture patients, they can be like at least after 2 hours, and 27.5% of them can be delayed. And one study which is very Malawi shows that 34% of adult patients can be delayed. And from the study on fracture that we do in Nawasa, 87% of fracture patients, they can be delayed. So delayed presentation are also complications. So our objective is to assess the prevalence of delay and the reasons for delayed presentation in patients among trauma patients. So the study is in Sidamari in our city. We selected 3 hospitals. One is government hospital, or specialized in hospitals, and the others are 2 private hospitals in the city, Ayatollah and Biane. The reason that we include these 2 hospitals are so that we can include all the patients who can afford to go to the private hospitals, and those who cannot afford to come to the government hospitals. In these 2 hospitals, private trauma and other hospitals, they have a single special, they give their care with specialists and subspecialists. Our hospital was university, so these hospitals match. The only difference for one is the expense of these specialists. The study was conducted from January 2021 up to December 31, 2021. It's a 1-year period, and the design is prospective
general cohort. And the study population is patients who sustain major trauma. When we see major trauma, we use the anti-inflammation technology definition of musculoskeletal, traumatic brain injury, neck, chest, cranial, maxillofacial, and abdominal injuries. So we calculated the sample size in the SMART calculation, and the sample size is 162, and we take all sampling patients consecutively. So every patient is trauma happen, we take it consecutively. It is fulfill the inclusion criteria. So the next we exclude patients who cannot give consent and who don't have the family to take care for them, like psychiatric patients who go by policemen. And patients who can do us more than one, we consider that as a chronic case, not an acute trauma, so we exclude those patients. We get our technical approval from University of Board, and data were collected by two general practitioners and two basic nurses were used, so that we want the data to be clear. Data entered into Excel and export spaces to version 36, and further training was done by the PI of the subject. So we use the univariate and holistic regression for analysis. And these are our results. So total is 1,262 patients that were analyzed. In the average, the study population is 33.3, and 84.1% of male. And total factors accounts for the most common cause of injury, reaching up to 65.7%. And most patients come to these three hospitals with referral. 75.4% have referral. So when you see the prevalence of related presentation, it is something 65.4%. So this is the modeling of average for related presentation. When we see the resident type, we have urban and rural. So we can see that for rural patients for rural areas, adjusted ratio is only 7 and p value is 0.06. So we have significant relationship. When you see the injury mechanism, brain injury accounts for 10% increase the risk of injury rate. And financial coverage, most of our patients they pay from their pocket, so maximum of the health insurance is not paid that much, so they are 1.68 times at risk of delay. And when you see patients who have bleeding or not, patients who have bleeding, that's 4.78% of delay. And when you see the prior health facility visit, most of the patients can just verify that means they are listed as a health institution. They are 4.03% at risk of delayed presentation. And when we see the neurological status, those patients who are not comatose, actually, most of the time the patient with consciousness, there is a high chance that the family will bring the patient to hospitals. So we think that is so it's totally different. It's quite adjusted for the ratio of the competition. So when we see the discussion, the recommendation is usually almost the same as the normal system, which is for fracture person. When you compare it with the Malawi, it is not worse. In the Malawi, it is around 61%, and it's more in our case. So from the mechanism of injury accounts for most of the patients who are delayed, and presence of bleeding and people living in the rural areas, and those patients who went to primary hospitals because they were referred to us, they are highly likely to be delayed. So we need to facilitate because those patients don't get definitive management at the first hospital or the first institution that they visit, they will be delayed at the hospital. So that increases the delay. So we need to facilitate patients in the institution that definitively cannot be given, they should be referred to patient as soon as possible. So the data shows significant burden in the presentation, and we need to have time calculated to stakeholders so that we can facilitate targeting the value it is. So this is my reference. Thank you.
Right, next talk is Dr. Efren. releasing the president, the future to be president. Now the vice president will be advantageous because we will have good people management and logistics. If we
So thank you very much. I'm presenting from impact of traditional setting or traditional quality of life of the school. It's a population study in the psychology. Ethiopia is part of OSAT study, and this is the theory component of the OSAT, which has publicated experts in this, and of course OSAT, a national building study. But fortunately, this was a separate component of the OSAT study. As you remember, that we have presented this OSAT study on the past two consecutive annual conferences. That was part of the pilot study, and the second one was the quantitative study. And since this is a multifaceted problem, we have to address the issue of quantitators in different perspectives. One perspective is the quantitative part, the other perspective is the qualitative, and there are also patients who are staying in the community who are